Mohan T. Shenoy. He is consultant endocrinologist. Welcome, Dr. Mohan. We are really eager to hear from you.
Yes, yes, thank you. So I will just share my screen. Can you see my screen?
Yes.
Yes, sir.
Yes, thank you very much. First of all, let me thank Dr. Samir Agarwal sir, Dr. Vineet, Dr. Rajiv Singla, Dr. Kalra sir for giving me the opportunity. And this is a debate with very important because I am fighting this battle with my own friend. So it will be a friendly battle, but it will be really harsh and it will be based on scientific evidence. Yeah, so let me start. So we are describing a condition called subclinical hypothyroidism, abnormally high TSH level with normal PT4 level without symptoms of hypothyroidism. Usually in non-pregnant adults, we usually treat them based on this waiting and watching 6 weeks. But because thyroxine is a safe drug, most often we try to medal it with the safety in the subclinical hypothyroid every indications and based on some empirical cutoffs. So I will be fighting this time with that over treating is happening in subclinical when you are not managing proper guidelines based. So let me start with the editorial because we all know that we read editorials. It remains a matter of editorial debate even now. You can see IJEM again showed the path. We had the Indian Journal of Medical Metabolism publishing this editorial 2013, way before the NEJM actually got into the act in subclinical hypothyroidism. So basically, it's because of ethics, because in mothers or pregnant unborn fetuses, we don't want them to have any problems. We generally wish them that we don't do any harm as well. So generally, we follow the codes of ethics. We follow the justice. We do patient autonomy sometimes, non-maleficence. So I will not bore you with this, but just to show that pregnancy, the patient is having very less choice because we are following some guidelines which are done from the Western literature. So this is the thing we are fighting. We are just having a friendly fight as well. It is like the movie 2.0 because we have two characters. The famous Akshay Kumar who was willing to become the villain for the scientific battle because he was fighting for the Earth, Mother Earth. And you have one side, one robot who was fighting in all cylinders. It required 3 robots actually to destroy the person in Akshay Kumar called Pakshi Raja. So just to show you that it is a battle with the doctor also faces daily. And in this fight with also many other conditions we are fighting, but remember that thyrovigilance in pregnancy is the one essentially required in our all practice. So is it a matter of scientific concern? How is it a matter of why I am telling these statements? So tremendous research and technical, lot of interest has happened in the fetus because the fetal thyroid does not produce thyroid hormone before 10 to 12 weeks gestation. And thyroxine is definitely imperative in early pregnancies most often. I will answer these questions. Is it judicious to start from the initial visit itself? Are we justified in following the guideline-based practice every time? Is the incidence of hypothyroidism estimated? I will call it further as SCH. Are there any regional disparities? Because we have had various areas which are reporting higher incidences. Does thyroxine therapy improve the pregnancy outcome significantly in SCH? And finally, how do we imply this in future offspring IQ and behavior? So we have to focus our interest because thyroid function reports are the most confusing reports. Add to that the influence of various confounding factors. We know that the BMI will increase in pregnancy. The age group of pregnant mothers is also increasing with infertility time. We know that assays are not uniform in our country. We know the community, there is no reference population in our community. Dietary iodine intake is a real problem because now despite we knowing that iodine sufficient areas are there, still there are many regions that I will name in my future slides that are various ethnic causes as well. And not to forget the diurnal variation, the fasting TSH issue, the illnesses, the medications that the mother will go through, and the gestational cutoffs. So remember that just a value of 4 will not be enough. We have to see that debate is also on the optimal reference range because one of the references range mentioned initially was 2.5. Later on became 4. Now it is going to 4.2. Indian data from Calcutta says it is 5. So what is the real cutoff? So we don't have no idea about guidance regarding upper limit of TSH. So next I will tell you why this is important because upper limit of TSH is variable. In China, we have seen a population data reporting a cohort value of 4.87, way beyond the 8-year recommended limit. In USA, many population cohorts have mentioned the upper limit as 5.09. The same authors of UK also mentioned the cutoff is 5.5. But within the population itself, the normal upper limit of TSH in African Americans was 3.6. Mexican is almost similar. Caucasians was 4.2. And to see one study done in Rotterdam, the largest population cohort of data using a cutoff of 2.5, even that population within that cohort had various incidents of subclinical hypothyroidism. Just to show it's a very big entity. Just to remember, a blanket treatment of thyroxine will not benefit in every patient. Why? Because HCG is like the counter hormone. We can see HCG is required for pregnancy. It declines towards the second trimester and stabilizes thereafter. And TSH is the one which is influenced initially. Once it climbs over, you can see the influence is a log linear relation with free T4. Definitely, we cannot measure free T4 in pregnancy, and T4 may not be good every time. So TSH as agreement is the test we usually follow. And we can see the Indians data mentioned in the 8-year recommendation is the data from Marwaha. It is a large data, included the iron sufficient iron exclusion area also. And even there, you can see the first trimester cutoff was 5, mentioned in Indian population. And second trimester, it was going up to 5.78. So my contention is that the cutoffs are like your goalpost. You change the goalpost every time for each trimester, but you follow the other side. Only Western data you are following of 2.5 and 4. So guidelines are not everything. Evidence-based medicine is what we are practicing. We are told that modern medicine follows. And a lot of data are haphazard based on continuous data, basically for prospecting on retrospective observational data on small sample size and subgroup analysis without correcting the confounding factors. So we can see here, the ATA themselves realized that 2.5 cutoff won't work. And then they changed the cutoff to up to 4. But we mentioned here that you should use a specific, the trimester specific cutoffs of your own area or similar population. Here, because we don't have a uniform population data ethnicity, we follow the last side, because as Indians, we know, we follow what is easy to us. So 4 is easy. So what about 4.1? What about 3.9? What about 3.99? Do you wait for them? Again, the cutoffs are very unclear again. You can see the antibody positivity. There are many assays who estimate antibody positivity just positive. 30 is positive sometimes. And some very measure like 100 is positive. So there is no empirical antibody level also mentioned here. So TSH 4.01, antibody just 32, you will just label as yes and you start treatment. This is not what is required. So here again, you can see 2 this is what 88 2017 mentioned. 2.5 to 4, again the gray area. Antibody again positive or borderline. What do you do? Again, you wait. But pregnant mother, what is the choice they have? We are just exposing them to a drug on again, we don't asking to test again. So we can again see, again TSH less than 4. You repeat them again after second trimester. Yes, you should do that. So definitely these are the ones which are clearly mentioned in the guidelines. So I briefly mentioned about the Marwa data. Here I can see that the population cohort was there. You can see that Delhi data is very clean on this, because they have mentioned clearly cutoffs are very clear. But I will just show you this data from Kolkata, published by my own friend, by Subodhik. He has mentioned regarding the various studies and why it's essential to develop population data on ethnic variation. Because after 2 decades of salt iodization, we have different environmental conditions. You can see the data from Jabba Singh from Manipur. See the low area of cutoff, 0.21 to 1.82. There is disturbance actually here. And you can see the study from Calcutta showed that the data of trimester cutoff was 0.19 to 4.34. Again, you can see the cutoff values is going up to 4.57 in second trimester. And the parallelly, we can see there are many other studies, notably the Rajput study done again on iodine sufficiency data. The UIC also seen there. You can see so many data are there, but again, the nowhere it's telling that 4 is the one to be done. So again, population trimester cutoffs are one thing. Do you measure the urine iodine concentration? Because in this case of this study, there are 500 patients included, published in IJAM. You can see non-pregnant cohort was also taken. There is definitely data suggests that there is no problem in giving a higher cutoff level. Exclude other factors also before you jump into diagnosis of subclinical hypothyroidism. Why I mentioned about iodine deficiency, iodine sufficiency is this data. This data published from China suggesting that iodine sufficient region, you can see anti-TPO level follows the U-shaped curve. That is the lowest prevalence of anti-TPO positivity when you have got UIC in the range of 150 to 249, suggesting that this data definitely part of the SHEPS data, the neuromotility outcome also studied. Definitely there is many things than what meets the eye. So maternal hypothyroidism, Dr. Om will definitely argue there are many things which similar to overt behavior, but these data are scratchy based on some retrospective data, small sample size. Definitely you can see that the incidences are very flip-sided in some cases. Subclinical hypothyroidism contributing spontaneous abortion. Again, there is a population data that placental immaturity may be one factor, and one more data that the TPO expression is there in the granulosa cells of placenta that may influence not only the autoimmunity. Definitely many things we need to study more into this. So the meta-analysis is one thing which we usually do. Meta-analysis definitely showed that there is increase in risk of perinatal mortality and preeclampsia. But zooming in further, the limitations were definitely that they included overtly hypothyroid women in the cohorts and non-matched cohorts. And there was inconsistency in the risk reporting. By this, we mean that the patient's reporting frequency was also difficult, and there was not capturing of the covariates of pregnancy risk, like other confounders also. And many of the studies in this definitely showed that it was underpowered to give the proper data. Even the Cochrane database was last published in 2010. There is not even evidence to suggest that go ahead for everything. There is limited interpretation because the obstetric outcomes are dependent on many other factors like infection as well. So this is the one which Negro had published and which we are all being tuned to hearing in our syllabus and our teaching. So anti-TPO positive in the first trimester with negative pregnancy outcome. But I'm just showing you 2 lines. The preterm delivery, you can see despite everything, only the very preterm delivery, and in that the respiratory distress was affected. All the other parameters were not having significant value, and the cohort was also homogeneous data. It was based on the woman in southern Italy on small corner where area of mild iodine deficiency was there. So that you know that Darulmia anti-TPO also was influenced. And again, you can see this data, a wonderful study which I could counter the Negro study. It enrolled a larger population size, large multi-center in 49 centers in UK, just published just 1 year back, enrolled 952 patients, but it had some problem because they recruited patients actively, screened them, and carried out half of them with levothyroxine and other half with placebo. There are definitely ethical issues in doing that, but definitely these patients, they are motivated and they had a history of miscarriage, infertility. Age group was also large, and the conceivation was active conception plan next 1 year. So these are not things mentioned in the Negro article. Even there you can see that the pre-pregnancy dose was fixed at 50, and again they did not increase it, and the primary outcome, no significant variation in any of the groups, conflicting the data of Negro et al. So what about Indian data? This wonderful article published again 2016 focused on the common, there is more than 1,000 patients were included here, and showed that though anti-TPO positive antibody was strongly associated with miscarriage and low birth weight, definitely no other complication like the Negro data was even mentioned in that, suggesting that Indian data is like this, but you follow the West because he's made a statement in the main journals. Again, the proof of concept of overtreatment further highlighted in the postal data, the pregnancy outcome studied in euthyroid men with because this data was focused on the data on 2.5 above. Definitely, you can see that there is definitely a role which is definitely negating the effect. And this meta-analysis is also focused on the patients who conceive naturally. Only those patients may benefit from the levothyroxine in reducing miscarriage, not in those using assisted reproduction. So, my friend, this is the main data which I have shown you. I am just telling the scientific data. The dosing of the levothyroxine in Negro data was very aggressive. That means the patients on the contradictory side had no choice. Other side was given no side. It is just giving you more and more levothyroxine. And then that's why you can see that the research levels were significantly lower compared to the other group. This is what I will argue in the pregnancy side. What about the offspring? Neurocognitive decline. We want the offspring to have a proper IQ. Again, the evidence again was showing clearly that it's only possible biologically, but not proven beyond doubt. But because you don't want to do any harm, you follow them. You follow them up to 3 years of age, 4 years of age, 5 years of age, even 7 to 10 years of age. But definitely, the data of the controlled antenatal thyroid screening trial published by Lazarus et al. In NEGM showed that there was no difference in the mean IQ in subclinical hypothyroidism mothers treated, and IQ at 3 years of age was also shown. This is the data which were again shown in 2017, again published again. Treatment continued beginning from 8 to 20 weeks of gestation, did not result in significantly better outcomes through this 5 years of data than no treatment for these conditions. So these cutoffs are all similar to that of the previous data. Number of patients was also 677. So proof of overtreatment, levothyroxine, this data just published January 2020 showed that overtreatment during pregnancy, there is a risk of higher adverse effects of childhood mental health outcomes. Just to show that you cannot underestimate this, there is risk of ADHD, autistic spectrum disorders. The population number was 485 again, and they had a lot of pairing studies done. So I will just end with these 2 points, just scaring the patient with the value of 4.1, 4.9, or just asking them to wait. Just wait for 3 days, again recheck. Maybe this study again just show you that the gestational data and maternal treatment did not have any change. And even the cutoff of 2.5 used in the first trimester did not have any association with adverse outcomes after 20 weeks. So this brings to my argument, are we treating in pregnancy, over-treating? The bottom line is, don't be in a hurry, derive the population-specific, region-specific data, repeat the TSH different assay, address the diurnal fluctuation because the patient itself has stress, maybe other medication, address the diurnal fluctuation, maybe you should repeat them. I have shown you all the data, just showing you that the cutoff levels is the one matters here, and subclinical hypothyroidism in pregnancy does not have any clear benefit or harm, or even empirical therapy has any benefit. Summarizing the data, just to show you that the data from the East data clearly mentioning that the pathogenesis of pregnancy loss may be only because of the hostile immune environment and not the thyroid hormone deficiency. So are we medicalizing pregnant state? I don't know, but this is the data. We are just a high jump, just putting the jump. We are increasing the cutoffs up and up. Then we will get less patients of subclinical hypothyroidism. Potentially, many women would be unnecessarily diagnosed as subclinical hypothyroidism and subjected to the therapeutic burden of thyroxine therapy. And even the US data just published 2019, the US database, even they showed that only 15.2% of the patients in US in this cohort, in this study database of 10,000 patients, will just show you that only that much patient received that thyroxine therapy. So even though they make the guidelines, the doctors, endocrinologists, they are not sure themselves. Even FOXI, ITS, ESI guidelines calls for collaboration. So complex clinical model has definitely makes us think about this data. So friends, I'm just concluding, even there are many ongoing studies going on. The final word is not sure about this idea. So my contest is that there is inadequate evidence base. Unless we have got strong evidence base, we cannot base our arguments on just a value. And we should not follow the guidelines blindly. Be careful when you blindly follow the masses, because sometimes the M is silent. And you know the example of the GPS signal, it can be lost sometimes unless you really be vigilant. So this much I will just conclude. So this is my friend Om. So he'll be arguing the other side. So I will take a break with my sides. Thank you.
Thank you, Dr. Shenoy, for very enlightening talk. Now I welcome my next speaker, Dr. Om Lakhani.
Thank you. Yeah. Are my slides visible?
No, not yet. Now it's visible.
Visible. Yeah. Okay. So first and foremost, I thank the Speed Group for allowing me to talk here. I think it's a great conference, and it's always lovely to be part of this. So I think my friend Dr. Mohan made two mistakes. The first, that he showed me with a beard, so I shaved my beard today. So I think it was not the Om which he showed in the end. The second thing is, I don't think he really addressed the actual problem. That is, what is the harm that you're doing in treating the patient or over treating the patient. I think that is the major challenge. So I'm going to talk against the topic, and I'm Dr. Om J. Lakhani. I'm an endocrinologist from Ahmedabad. So first and foremost, my very important contention is that to get the right answers, we need to ask the right questions. And in my talk, a lot of the times obstetricians and gynecologists often tell me that, hypothyroidism pregnancy ko tumne itna complicated bana diya hai that we don't know what to do, right? So what I'm going to do is I'm going to keep my differences aside from Mohan, and because he's a very dear friend of mine, and I'm going to make this talk very simple for all the obstetrician and gynecologists to take home and perhaps, perhaps modify their practice to what is current and what is relevant. So Dr. Tim Koreva recently had a tutorial on this topic, and he actually started with a question. And why Dr. Tim? Because Dr. Tim is an authority on this topic, and also, Dr. Mohan referenced him in one of the slides that he showed. He said that, he asked this question on Twitter and to the Twitterati, and he asked that, do you treat subclinical hypothyroidism during pregnancy? And interestingly, of 780 votes, which is good number, 48% people said yes, right? And 27% said it's complicated, but perhaps they said yes. And I would say only 23% said no. So I think the majority, and I think, if you ask all the people in this room, I would say all of them would perhaps, will get a similar result in that scenario, except perhaps Mohan would say no, because he is mandated to say that. Okay, so the right questions to ask are, first question is, are we correctly diagnosing subclinical hypothyroidism? That is the first question. Second is, are we treating the right patients? And third is, what do I do in my practice? That is the most important thing, and that is what you will have to take home at the end of this debate. So the first question is, are we misdiagnosing it? And that is where I completely agree with Dr. Mohan, right? The data of TSH of 2.53, 3.5 was actually based on one study done from the NIH, which perhaps took a strange population and got a strange result. And because of that, because it was from the NIH, it had that, eminence bias, and it got stuck for us for a long period of time, ended with confusing us for a long period of time. So I think 2017, the ATA corrected this and clearly said that whenever possible, you use a population-based trimester-specific range. So the next question is, what is our reference range? So in this, again, I'll not confuse you. I'll give you just one study done from Dr. Rajput. Why Dr. Rajput? Because it's a relatively recent study. It's published in a established Indian Journal of Endocrinology and Metabolism. And it is very similar to the population we are addressing today, that is in the Northern Indian population. So in this study, he has clearly shown the TSH cutoff, that is 97.5th centile, is 3.69 in the first trimester, 4.47 in the second, and 4.6 in the third trimester. Very simple cutoffs. Just remember these cutoffs. And in case you are not able to remember the exact value of 3.69, or perhaps your population is different from Dr. Rajput's population, perhaps you can use a cutoff of 4. Again, it is not a simple number. It's a magic number. There are reasons why the importance of 4 number, and I'll actually show you with important randomized control trials to show why the number 4 is important, right? So if you cannot remember 3.69, use the cutoff of 4. And from henceforth, I'm going to use a cutoff of 4 because it is, again, like I said, simple to understand. Okay, the next question, the very important question and the elephant in the room, is there any data to show that subclinical hypothyroidism in pregnancy is associated with adverse clinical outcome, right? Like Dr. Karthik told you, the highest level of evidence comes from meta-analysis. Dr. Mohan beat around the bush. Ultimately, I'll show you one meta-analysis done by Dr. Maraka et al., where they clearly showed that subclinical hypothyroidism is associated with increased pregnancy loss, increased placental abruption, increased premature rupture of membranes, and increased neonatal death. Now, my friend Dr. Mohan is a pediatrician, and I'm sure he's worried about neonatal death, because ultimately that is what no pediatrician wants at the end of the day, right? So the meta-analysis clearly shows that subclinical hypothyroidism in pregnancy is associated with poor obstetric and neonatal outcome, right? I think it is as clear as it could be, right? But the next question which you should ask is that, fine, it is associated with adverse outcome, but does treating it with levothyroxine reduce the risk? That's the relevant question, and that is again what I'll address further in my talk. Okay, so coming back to the second question, that is, are we treating the right patient, and is levothyroxine the right form of treatment? So that is the second question that we'll address. So first of all, I'll divide this into 2 groups, anti-TPO positive patients and anti-TPO negative patients. Why this is important? Because I very strongly believe, and I'll show you from the data also, anti-TPO antibody has very strong correlation with poor obstetric outcome, even more than thyroid dysfunction. And hence, I would say that if you are a practicing gynecologist, please don't forget to do an anti-TPO antibody in your pregnant women with subclinical hypothyroidism, because your decision for further treatment depends on this. I get a lot of referral, and I tell, always check whether the gynecologist has asked for an anti-TPO. If not, I will ask for an anti-TPO antibody. So first of all, ask for an anti-TPO antibody, right? So now we have done the anti-TPO antibody. We'll divide the group into three things. TSH less than 4. Why 4? I repeat again, because 4 is the limit. 4 is the generally accepted upper limit in the first trimester. For Dr. Rajput's population, you will have to use 3.69. For everywhere else, check your local data. If there's no local data available, use 4. That's a simple message to give you, right? The second group is 4 to 10, and the third group is more than 10. First, we'll address the simplest one, that is more than 10. I think it is very clear. Nobody in this group, nobody listening to this will say that you don't need to treat this. Any patient with TSH more than 10 should be considered an overt hypothyroidism in pregnancy and should be treated. There is no doubt about it. It's like saying that, find me evidence for, whether parachute works when you're jumping from an airplane. Answer is no, you don't need an evidence for that. You just need basic common sense, right? You will never do a randomized control trial to check, push 10 people with a parachute and push 10 people without a parachute. I think, that is clearly not asked for. What about TSH less than 4, right? So less than 2.5, there is no indication for treating. So if you have anti-TPO antibody negative with TSH less than 2.5, there is no indication to treat. What about TSH 2.5 to 4? Well, there is some evidence for benefit, but it is very weak. And generally speaking, I'll come to this topic again. Again, it's a gray area. I'll come to this topic again in a few minutes. But currently, remember, your current definition of subclinical hypothyroidism does not include TSH of 2.5 to 4, right? So when you're talking about subclinical hypothyroidism, you are talking about TSH more than 4. You are not talking about this range, and hence this is not relevant for a debate. However, because, I'm so graceful, I will actually talk about this point also in a few minutes. Okay, coming to the second issue, that is the group which is, sorry. Yeah, that is the group which is 4 to 10, right? This is the important group, right? This is the gray area. Why I shaded this gray? Because it's a gray area. In this, I will not again confuse you with many studies. I'll just show you one study. Why one study? Because this is a randomized controlled trial. It is done by Dr. Nazarpour from Iran. It is published in Journal of Endocrinology and Metabolism. And if you read this study, if you read the complete trial, you will realize that this is a beautifully done, very well conducted study. And they've considered only one outcome, that is the early pregnancy loss. That is the only outcome they've considered. And but this trial, right, this is subclinical hypothyroidism negative anti-TPO antibody. What is the outcome, right? So hold your breath. This is the study. This is the overall, the design of the study. I'll not go into too much detail of this, but what are the results? The results, and you can see here clearly on the screen, the group A is the one which were having subclinical hypothyroidism and who were treated with levothyroxine. Group B was the one which was not treated. Group C was a control group. You can clearly see in women who are having TSH less than 4 and TSH more than 4, you can see in women who are having TSH more than 4, treatment had a bad pregnancy outcome, that is early, early or preterm, delivery of 7.3%, which is, lower than 19% in the women who are not treated. And as the study concludes, that whereas treatment in women with TSH more than 4 has clearly benefit in terms of reducing preterm delivery. However, this study also shows that in the group of 2.5 to 4, there is no clinical outcome, no positive outcome, right? Which means that in that group, there is no benefit of treating with levothyroxine. Once again, I am telling you, right, levothyroxine more than 4 is the definition of subclinical hypothyroidism and not 2.5. Forget 2.5. I don't know where it came from. You need to just forget about it. We need to close that chapter. Your current cutoff should be 4 or 3.69 or whatever value that your that your own center or your own location tells you. The second group is the anti-TPO positive group, right? So we talk about anti-TPO positive group. We'll divide it into 4 categories: more than 10, less than 2.5, and somewhere in between. More than 10, again, I'm sure everybody will agree with me that you have to treat this women. There is no doubt about it. Less than 2.5, I'm sure everybody will agree with me that you don't have to treat it. Reason, there is technically it's a gray area, but a recent tablet trial which my friend can we, there's some disturbance, can we, my friend Dr. Mohan talked about this trial, that is the tablet trial. The tablet trial showed that in euthyroid women with TPO positive, there is no benefit of treating, right? Again, this is not an area of our debate. We are talking about subclinical hypothyroidism, but less than 2.5 with anti-TPO positive, you don't treat. There is no data to show any benefit. What about 4 to 10, right? This is again a contentious area. This is the main area which we are discussing today. So TSH 4 to 10 with anti-TPO positive. Again, I'll tell you, a study from the same author, right? Why I'm doing this? Because it's a very well conducted RCT, again published in Clinical Endocrinology, highly reputed journal, very well conducted study. Effects of levothyroxine treatment in pregnancy outcome in pregnant women with autoimmune thyroid disease, meaning anti-TPO positive, also from Dr. Seema Nazarpur, right? Well done RCT, right? When you have one well done RCT, perhaps, I think, that clearly makes your day. You don't need to find 10 other evidence, right? Which may not be a well conducted study. What are the results of this study? Again, it clearly shows the group A was the one where there was treatment. Group B was the one which was not treated. Group C was the control group. You can clearly see the group A, that is TSH in a subclinical hypothyroid range with anti-TPO positive. There was reduced preterm delivery and neonatal admission. Again, group B, there is clearly, which is not treated, you can see almost 23%. You can almost see 3 times more, preterm delivery, 3 times more hospital admissions, neonatal admissions. Again, my friend is a pediatrician, I should remind you, and he doesn't want neonatal admissions, right? He's now an endocrinologist and doesn't want to waste time treating neonates, who perhaps, that endocrinologist should have treated at the right time. Again, the small points from the discussion, again, this study also shows that the benefit is in women who are TSH, who are having TSH more than 4 with anti-TPO positive. Again, I'm telling you, subclinical hypothyroidism, TSH more than 4 with anti-TPO positive, that is the group you should treat. Okay, so it's very clear here that, the yellow group is the one you should also consider treating. The red group, of course, you are going to treat. Coming to the other gray area, that is TSH of 2.5 to 4. Again, I'm telling you, boss, this is not the area of our debate, but I'm just trying to give you some data. Again, a study, a meta-analysis done by Dr. Korevar again shows that, anti-TPO positive itself induces a slight higher risk of preterm delivery, risk of miscarriage. Also, the higher the TSH, more the risk of miscarriage, right? So this is clearly shown. And in this meta-analysis, well done, you can see on the bottom, TPO positivity 1.3 odds ratio of miscarriage, TPO positivity TSH more than 2.5, 1.36, but more than 4, it is 1.55. So it clearly shows that higher the TSH, more the more likelihood of having a TPO with TPO antibody positive, more likelihood of having a miscarriage. No gynecologist in this room likes a miscarriage. Nobody likes a miscarriage. Why do you want to take the chance at all, right? When the data clearly shows that, benefit treating it reduces the risk of preterm and miscarriage, right? Dr. Korevar also gives a expert opinion that in those 2 gray areas, that is, a 4 to 10 with TPO negative and TPO positive women with 2.5 to upper limit, that is 4. There are certain cases where you should consider treating, that is twin pregnancy, because you have higher HCG. Remember, higher HCG means lower TSH, right? Repeated TSH above 7, again an expert opinion. If you have very high anti-TPO antibody titer, you are more likely to have thyroid dysfunction. Remember, if you have higher TPO, you have less response to HCG also, right? So that is also which is shown by Dr. Korevar. And if you have a history of previous miscarriage or preterm delivery, in all these conditions, you should consider treating it. These are the solid gray areas, right? But again, the expert opinion is this. Finally, the ATA guidelines says that when you have TSH more than 2.5 with anti-TPO positive, you should consider treatment. However, the recommendation is weak with moderate quality of evidence. Again, we are just discussing this point to complete the list. 2.5 to 4 is not our area of debate. Our area of debate is more than 4, and which we have clearly shown that there is no doubt you should consider treating, and the guidelines also suggest the same thing.
Dr. Om, I think you need to bind in next one.
Sure. I'll just conclude. I just conclude my talk. What you should do in practice. Okay. So I hope I have not confused you. I hope I've kept it very simple, but I'll also make it even more simple by this simple slide. If you're sitting at home, right, just take a screenshot of this. This is all you need to follow. If you're a practicing gynecologist, don't get confused by what Dr. Mohan is arguing, right? Just follow this because this is evidence-based and this is based on the guideline, right? If you have a high-risk woman, check the TSH as soon as the pregnancy is confirmed. Get an anti-TPO antibody also done, right? Especially if the TSH is between 2.5 to 10. If the TSH is between 2.5 to is less than 2.5, send the women home. Be happy, nothing is going to go wrong. 2.5 to 10, well, not exactly, but 2.5 to 10, if the TPO antibody is positive, if it is between 2.5 to 4, you can consider treating it, right? Again, we are not arguing this. That's a separate debate altogether. If it is between 4 to 10, you should definitely consider treating it because these women are at a higher risk of preterm delivery or miscarriage. TPO antibody negative women between 4 to 10, you should definitely consider treat. Even though it says consider treating, I would say you should definitely consider definite treat because there's an asterisk there. And Nazapur study in JCEM in 2018, which was published after the guideline, has shown clearly there is benefit of treating and reduces the risk of preterm delivery. And if it is between 2.5 to 4, don't treat it if it is TPO negative, because again, that's not an area where you should consider treating. So with this, I wind it up. I hope I made it simple for you. And I hope we have, me and Mohan both together have tried to answer this question as definitively as possible. Thank you for a patient listening.
Thank you, Dr. Shenoy. Thank you, Dr. Om Lakhani, for a wonderful discussion. And I will summarize. I think under-treatment or over-treatment, both are bad. And definitely, we all know hypothyroidism has bad effect on pregnancy, like preterm delivery, miscarriages, IUGR, and bad neonatal outcome. But we have to balance and we have to see what patients we are treating and what population we are treating. We have to consider TSH as well as anti-TPO antibody, as Dr. Om Lakhani very well said, and gave us different guidelines about, and one thing we are sure about, that we have to treat patients when TSH is more than 4 and TPO antibody is positive, and that is the take-home message. I think that is very important point. Thank you, sir.
Thank you, everyone. Thank you.
I think very, very excellent debate. Dr. Sajada Salim, any comments from your side? Sir, you have to.
Thank you. This was a very brilliant, very also practical debate. And probably many of the joining or participating endocrinologists are in doubt. But after having the discussion of these two prominent speakers, and they have presented the data, many of the doubts from the mind of many of the practicing endocrinologists or others have removed, and they will be very much confident in treating the patients with subclinical hypothyroidism. It goes to me. I am grateful to the speaker, both the speaker, though we are waiting for the next session and it is getting delayed, but I am very much happy to listen to these two speakers. Thank you. Thank you, the speakers.